It's a real honor to have one of our pediatric nephrology, adult nephrology attendings, AC Gomez, talking today about pediatric nephrology. AC did her med school in Penn and residency at Baylor, and then both peds nephrology at Boston Children's and adult nephrology at MGB, and a transplant fellowship. And we unfortunately don't have an interventional nephrology fellowship, otherwise she would have continued. And she's now joined the faculty, and she's going to be setting up a bridge clinic for pediatric graduates from Boston Children. So really looking forward to her inaugural talk on pediatric nephrology.
All right. Thank you, Dr. Mount. So like you mentioned, I'm AC Gomez. I'm an attending in the Division of Nephrology here at Boston Children's and then also at Mass General Brigham, and an instructor of pediatrics. And my focus is transitions of care in chronic kidney disease and transplant. So very excited to be talking to everyone today about pediatric nephrology and CKD through the lifespan. I do not have any relevant financial relationships or disclosures to make. And in terms of objectives today, so the goals are to understand the approach to common pediatric nephrology problems that are encountered by adult nephrologists, and we'll talk about why that's important. Distinguish pediatric and adult definitions of and approaches to nephrotic syndrome and hypertension, since these are some of the more common things that you may see. Recognize childhood kidney conditions that present a risk of CKD in young adults, and understand the core elements of transitions from pediatric to adult kidney care. So first, why is pediatric nephrology important and why is it relevant to adult nephrologists? So this is data from 2019, so it is a little bit old, but it is the most recent data that we have, where there were only 651 certified pediatric nephrologists in the country. And you can see here how that breaks down per region and per 100,000 children. So for a lot of people going into, adult nephrology, you may actually see called upon to see pediatric patients or adolescents and evaluate them if there is not a pediatric nephrologist available. And so I think this is important for everybody to know and to understand. So the first topic that I'll talk to you about today is pediatric nephrotic syndrome. And we'll start with the case. So it's a previously healthy 4-year-old who presents in the spring with rhinorrhea and eye swelling. They're initially referred to allergy and immunology for management of seasonal allergies, which is actually probably one of our most common referral bases are from our allergy and immunology colleagues. These kids often get referred there with a diagnosis of allergies. And at that visit was noted to have a 3-kilogram weight gain from a recent well-child check, and so was referred to a nephrology clinic for evaluation. Blood pressure was normal. Creatinine was 0.3, which probably seems wildly abnormal to most people here, but for a 4-year-old is completely appropriate. An albumin of 1.2 and a UA with 3+ protein and a spot urine protein to creatinine ratio of 3. So the first question is, what is the next best step for this patient? So A, kidney biopsy to help identify the cause of nephrotic syndrome. B, genetic testing to identify the cause of a possible podocytopathy. C, initiation of empiric glucocorticoid therapy. Or D, initiate loop diuretics for edema and 3-kilo weight gain. All right, so it looks like the answers are changing a little bit, but kind of split between, some people would do a kidney biopsy, some people would do diuretics, genetic testing, initiation of glucocorticoid therapy. So let's talk about the next best steps. So in this case, the recommendation would typically be, I guess if we can stop the polling. But the typical next best step would be initiation of empiric glucocorticoid therapy. So we'll talk about the definition of pediatric nephrotic syndrome. Let me see. Sorry, I messed up my slides here. I have you pinned, and I don't know how to unpin you because I think I pulled up the responses, but that's okay. All right. So in terms of the pediatric nephrotic syndrome definition, so proteinuria with a spot urine protein to creatinine of 2 grams per gram, which is obviously lower than in adults, or of greater than 1,000 milligrams per meter squared per day. Hypoalbuminemia with a serum albumin of less than 2.5 grams per deciliter, hyperlipidemia and edema. So some things fairly similar to adults, but a lower threshold for the proteinuria there. And then just in terms of some practical tips for the measurement of proteinuria in kids, a spot urine protein to creatinine ratio is always used in children because of difficulty of a 24-hour urine collection. So that's just never something that's feasible in kids to do a 24-hour urine collection. So we always do a spot. It's always a first morning dipstick. And so for patients, it's really important to counsel them. A lot of our pediatric patients have orthostatic proteinuria, and we're really not interested in quantifying that. That is benign. And so we always want to counsel patients that the kids should like brush their teeth, do their normal nighttime routine, and then void the last thing before they go to bed. And then the first thing in the morning when they wake up, before they brush their teeth, before they eat breakfast, before they do anything else, they should void in a cup that we give them. And then they bring that to clinic and we can do the dipstick. In non-toilet trained children, you can teach them to put cotton balls in the diaper overnight and then squeeze it onto a dipstick. And trace and microscopic hematuria can be seen in minimal change disease, just to know. In terms of pediatric nephrotic syndrome, the incidence by age. So we most commonly see this. It's rare at any age, but it's highest incidence in preschool age children. So especially you can see around like age 2, 3, 4 years old. And in pre-adolescence, the incidence is higher in boys. So it's 2 to 1, boys to girls, but post-puberty, the incidence is similar. In terms of why the next best step would be initiation of empiric glucocorticoid therapy. So in 1981, there was a study where all children were biopsied at presentation. And what they found was that 80% of those children had minimal change disease and 10% of children had FSGS. And we'll talk about some of the distinguishing features of both. But as a result of this, we basically know the overwhelming majority of children who present with nephrotic syndrome are going to have minimal change disease. And that's generally now defined as response to steroids. In terms of the presentation, minimal change disease, you can see they're 80% present at age less than or equal to 6 years old. Majority are going to be boys. And we talked about 2 to 1 kind of pre-puberty, but later that evens out a little bit. Fewer of them are going to have hypertension or microscopic hematuria, but a quarter of them can have microscopic hematuria, and fewer of them will have elevated creatinine. That's a little bit unusual for minimal change disease. Whereas you can see the patients that present with FSGS tend to be a little bit older. They tend to have more hypertension, more microscopic hematuria, and more often an elevated creatinine. So, you can see there's a lot of overlap in the presentation of these in kids. But in general, if you have a young child without atypical features, so normal kidney function, no hypertension, you're going to lean more towards minimal change disease and initiate empiric steroids. The when and why of empiric steroids, again, we talked about this kind of typical presentation and what that means. And we also always do a urine sediment when we examine them in clinic. And so if they do not have any concerns for nephritis on the urine sediment, then that would be another thing that would point you towards doing empiric steroids. When we consider a biopsy or genetic testing in these kids, infantile or congenital nephrotic syndrome, so a presentation at age less than 1 year of age, should always be followed by genetic testing. And the overwhelming majority of those patients will have a genetic diagnosis, and that's a very unusual age of presentation. Sustained hypertension or kidney dysfunction, gross hematuria or red blood cell casts on the sediment, and a low complement or other systemic features. So the big thing to know for the boards here is in childhood nephrotic syndrome, in the absence of atypical features, the best test, if you will, for the etiology is their response to steroids. In terms of steroid therapy in children, you do not need to memorize this for the boards, but just to know it's 60 milligrams per meter squared of prednisone for 4 to 6 weeks. In children, obviously, everything is typically either weight or height or BSA-based dosing, followed by 40 milligrams per meter squared on alternate days for 4 to 6 weeks, and then a wean over 4 to 6 weeks. So the real thing to know for steroid therapy in children is that even if they respond quickly, which most of them do, we keep them at the full dose for a full 4 to 6 weeks to reduce the risk of relapse. And that this is a long time on steroids and a long taper for children. And this is just for the initial management. So it's typically at least 3 months of steroids in the beginning. In terms of time to response, though, the average time to response is 10 days, and over 90% of responders will respond by 4 weeks. So it's very unusual to not have a fairly quick answer to this question. And then we categorize children in terms of their relapses. So steroid responsive children respond and go into complete remission within 4 to 8 weeks. Steroid dependent children typically relapse either during the steroid course, so during the taper, or within 2 weeks of stopping. Steroid resistant children or children that don't achieve complete remission within that 4 to 8 week window, and then frequently relapsing children have 2 or more relapses within the first 6 months, or I think I said 4 or more, but I think it's actually 3 or more relapses in any 12-month period. And so I will say around 80% of children will have a relapse following the initial glucocorticoid treatment, and that number has decreased a little bit over time. It was previously 90%. It's down to maybe in some studies around 70%, so we call it typically 80. And around 56 to 76% of children will have frequent relapses or become steroid dependent in order to maintain remission. So steroid dependent or frequent relapsing is and at least one relapse is very often the norm in these children. And I think that's important to counsel parents and patients on when they have that initial presentation, because it's very scary for them. And I think it at least alleviates some of that anxiety to know that the vast majority of children will relapse, so they at least know to expect it. In terms of steroid-sparing therapies, we typically have 3 second-line agents, if you will, to help reduce the exposure to steroids in kids who are steroid-dependent or frequently relapsing. So MMF, rituximab, and a CNI. The MMF, the pros are that it's not nephrotoxic, and there's typically no drug level monitoring needed, so we don't do any routine drug level monitoring for MMF. The cons are an increased risk of skin cancer, so we always counsel them on sunscreen and sun avoidance. And then the data do unfortunately show a little bit better outcomes if it's dosed by the area under the curve rather than BSA, but that's much more difficult to do. It requires kind of serial levels each hour after the dose is given for a few hours. And then we typically do one adjustment, but most centers don't do area under the curve dosing. They just do BSA-based dosing. But there are some data showing better outcomes if you do if you target a higher area under the curve, and we know that the absorption is very variable when we do BSA-based dosing. Rituximab, the pros are that it's an infusion, and afterwards children are less likely to revert back to a frequently relapsing or steroid-dependent phenotype and compared to the other therapies. So typically we do these therapies for about 1 to 2 years if they are frequently relapsing or steroid-dependent to try and reduce the exposure to steroids, because a lot of children will have fewer relapses as they age. The cons are that it's an infusion, so some children don't really do well with infusions, or it may be too difficult to get an infusion set up, or you may be far from a center that can do it. And there's a variable duration and benefit. So similar to when we use rituximab for other indications in adults, it depends on when B-cell reconstitution occurs. And then CNI, the pros are, in addition to the immunosuppressive effects, you get stabilization of the podocyte cytoskeleton, and tacrolimus has more standard drug monitoring than MMF. The cons are that it can be nephrotoxic over time, and there's need for frequent drug monitoring and timed drug monitoring, which can be very difficult to do in school-age children, both because of the typical kind of fear of blood draws, as well as it's just difficult to get that timing done while they're in school. So ultimately, the preferences vary center to center and patient to patient. There's no one right answer for the next therapy for children, and all of these are viable options. In terms of important adult considerations for pediatric nephrotic syndrome, so if you have a patient who's transferred with a pediatric diagnosis of nephrotic syndrome, you need to know their original presentation and whether or not they've ever been biopsied, their steroid sensitivity and relapse pattern, and just be aware that that can change over time. Prior exposure to MMF, CNI, rituximab, or other immunosuppressive agents, including the timing and duration, whether they've ever had issues with steroid toxicity. So all of our children have monitoring of their growth, their bone health, their eye health, and metabolic complications, their vaccination and infection history, and then reproductive counseling needs, particularly if you're considering starting them on a teratogenic medication. So next, we're going to talk about pediatric hypertension. So we'll start a next case here. So a 10-year-old boy presents for a routine well child check. He's a former 28-weeker who initially required ventilatory support in the NICU, has had periodic febrile illnesses in the first few years of life. What kid hasn't? Height is 25th percentile and weight is 40th percentile. And blood pressure at the well child check was 130s to 140s over 80s on repeat oscillometric blood pressure readings. Creatinine was 0.6 milligrams per deciliter, and a BMP was otherwise within normal limits, and a urinalysis was unremarkable. So the question is, what's the next best step? A kidney ultrasound with Doppler, plasma renin and aldosterone, initiate amlodipine at 0.1 mg per kg twice a day, which is the correct dosing for pediatrics, I promise. Confirm cuff size and measure a manual blood pressure, or diet and exercise counseling with recheck within 3 to 6 months. Okay, so in terms of next best step for this patient, so we can, sorry. There we go. Oh, what did I do? Okay. Okay, so in terms of next best steps for this patient, the next best step is to confirm the cuff size and measure a manual blood pressure. So that's always the next best step in pediatric hypertension. You always want to confirm any oscillometric blood pressure reading with a manual blood pressure, and we'll get a little bit into why. So pediatric blood pressure measurement, what is the correct cuff size, which I think this is also very relevant for adults. I see a lot of patients get measured with the wrong blood pressure cuff size. So the width needs to be greater than 40% of the mid-arm circumference, and the bladder length needs to be greater than 80% of the arm circumference. I realize almost nobody remembers these rules. So what you can just do is measure the arm circumference, and then manual blood pressure cuffs always have the range that they fit written on the blood pressure cuff itself. So if you're ever not sure, measure their arm circumference in clinic, and then you can see an example of a blood pressure cuff here, and you can see that it actually has the range that it is appropriate for written on the cuff. The reason that we always confirm oscillometric readings with manual ones is there was a 2001 Tampa school-based screening of 7,000 children aged 5 to 17 years old, and they found that oscillometric readings were higher by around 10 millimeters of mercury systolic and 5 diastolic. And then obviously also always do an upper extremity blood pressure reading, but that's a significant differential in terms of the blood pressure. The standardization is based on an appropriately taken manual blood pressure. And the oscillometric blood pressure readings also measure a mean arterial pressure, and then they all have proprietary formulas to extrapolate the systolic and diastolic blood pressure. And all of the different companies that produce oscillometric blood pressure machines have different proprietary formulas. They'll get you different answers. And so always, always, always do a manual blood pressure. In terms of pediatric hypertension, what even is it? So less than age 13, a normal blood pressure is less than the 90th percentile, and these are all based on sex, age, and height. So there's tables for all of these. An elevated blood pressure is the 90th percentile to less than the 95th percentile. Stage 1 hypertension is the 95th percentile to 95 plus 12, and then stage 2 is greater than or equal to 95 plus 12. So the one that I always remember is stage 2 is 95 plus 12, because it's kind of an odd one to remember. But if you backtrack from there, the fact that it goes by 5 percentile basically at a time kind of makes sense to me. And then over age 13, we use the more traditional adult cutoffs. The one thing to know is if there's ever in age, sex, and height percentile that you see here that exceeds the adult cutoffs, you use whatever is lower. So additional evaluation for this patient. So assume that it was confirmed on a manual blood pressure reading. So this patient then went on to have a kidney ultrasound that revealed a normal left kidney and a right kidney with a 2-centimeter focal upper pole scarring and a subsequent BCUG with grade 3 right-sided reflux. So we do always think about this just in kids that have had kind of unidentified febrile illnesses of childhood where the parents don't really have a good alternative explanation. They didn't really seem sick. A lot of times we are concerned that they may have had undetected UTIs. So evaluation of pediatric hypertension, things that you need to do. So always repeat a manual blood pressure, ensure the correct cuff size, consider an ambulatory blood pressure monitor for 24 hours. And this should be done for all children in whom it's developmentally appropriate. So any neurotypical child who's typically over the age of 5 or 6 should have an ambulatory blood pressure monitor for 24 hours to confirm a diagnosis of hypertension, and then also to assess the pattern of hypertension. So do they have masked hypertension, white coat hypertension? Do they not have appropriate nocturnal dipping? They should have a urinalysis, a BMP, and metabolic screening if it's confirmed, a renal ultrasound in some cases, sleep evaluation if there's nocturnal hypertension, because that raises a high concern for OSA, and then an echocardiogram in kids if we're considering pharmacologic treatment or we suspect target end organ effects. And in kids, part of the reason for this is kids don't often get blood pressure readings as part of their routine well child checks, depending on their age. And pediatric hypertension may go undetected for extended periods of time. So we do unfortunately see a lot of kids present already with left ventricular hypertrophy at the time that we're thinking about considering therapy. In terms of the choice of agent, it should be based on the underlying pathophysiology similar to adults. So you want to consider an ACE or an ARB if there's proteinuria, thiazides if there's concern for volume-mediated hypertension, and a calcium channel blocker is never an incorrect answer. It's typically well tolerated. Check the pediatric dosing if you don't know it. So check the mg per kg dosing, although we do tend to cap out at the adult dosing. And then check the frequency. So things like amlodipine, for example, kids more rapidly metabolize it, so it's dosed twice a day in children. And then titrate up to the max dose as needed, and your target is less than the 90th percentile or less than 130/80, whichever is lower. So in terms of pediatric CKD and the relevance to adult CKD management, so some of the causes of pediatric CKD, you can see here, so CACUT is one of our most common causes of pediatric CKD, followed by glomerulonephritis. And you can see that in terms of the etiologies of ESRD, the breakdown is slightly different because a lot of our GN patients, unfortunately, will progress to ESRD, whereas a smaller percentage of our CACUT patients will ultimately progress to ESRD. And as with adults, when we think about ESRD and CKD and mortality, what we know is that the main causes of mortality are cardiovascular disease and infection. So that is true for adults and it's true for children rather than the renal failure itself. We also know that children tend to present late to nephrology care. So there was a study in the UK that showed that 1/5 of children present late, meaning that they need kidney replacement therapy within 90 days. And so it's just important to kind of think about when you have a diagnosis of childhood CKD, that this may go undetected for a long period of time. And then the causes obviously change with age. So a lot of our CACUT patients are picked up early, particularly with mothers very often getting prenatal ultrasounds now. So that as a overall percentage of CKD is obviously the biggest in the beginning and then kind of decreases with age, whereas FSGS and other glomerulonephritis, or not other, but glomerulonephritis increase with age. And the reason that we think of FSGS as a separate bucket here is because it is the main nephrotic syndrome that causes CKD. So a lot of our pediatric patients will have minimal change disease, but FSGS is the one that typically progresses to end-stage kidney disease in our kids. So childhood CKD and the effects into adulthood. So we'll go through some of these. So first are the cardiovascular effects of CKD, which again is similar to adults. So anemia and hypertension and subclinical cardiac disease in childhood are big ones. So calcification and endothelial dysfunction lead to left ventricular hypertrophy and increased risk of cardiovascular events, worsening CKD progression, and then myocardial infarctions and sudden cardiac death. And it's important to know that the mortality in children with end-stage kidney disease is 30 times that of their healthy peers. And again, the main cause of mortality are cardiovascular disease and infection rather than the renal failure itself. Kids with CKD are at high risk of inadequate nutrition and growth failure, which affects them as adults. So there's not a lot of indications for growth hormone, but CKD is one of them. And in addition, kids can have significant issues with neurocognitive development, even in the mild stages of CKD, and increased risks of anxiety and depression. So all of those things need to be screened for. And I think the the mild kind of neurocognitive deficits, and some of them may have more significant issues with neurocognitive development. But it's just something that we need to keep in mind, because I feel like in kids with chronic kidney disease who transition into adulthood, we often think of them as non-compliant or having delayed adolescence and things like that. And we may also need to realize that a lot of them are very, very good at masking mild degrees of neurocognitive dysfunction. CKD, MBD, obviously similar to kind of, adults, a lot of issues with their bone development. And then premature birth and low nephron endowment and low renal reserve can lead to CKD later in life. So things for you guys to know are that nephrogenesis completes around 36 weeks of life, but there's a lot of postnatal changes. And IUGR, which is intrauterine growth restriction and prematurity, are known risk factors for reduced nephron mass and issues with kidney development. And this is particularly now important to adult nephrology, because it was really in the 90s when we started to be able to resuscitate infants less than 28 weeks, and now down to like 22, 21 weeks. And that was a lot because of our changes in kind of ventilator management and surfactant. So now we're starting to see these patients who really had significant issues with nephron endowment and premature birth transitioning to adult care. And so other things are for kids with things like solitary kidneys, et cetera. There's a risk of insufficient hypertrophy and compensation, and that especially happens in adolescence and early adulthood. So a lot of these kids with either reduced nephron mass or solitary kidney or these other kind of Keck-Hood issues, they may do well throughout childhood, and we monitor them for hypertension and proteinuria, and they do well. But I think a lot of times in the adult world, we see them and we feel like they kind of come in crashing and burning and really falling off of a cliff. And one thing that's important to know is that a lot of that has to do with the fact that they have significantly increased metabolic demand that they just cannot compensate for as they grow and go through puberty. And so there's a significant progression of CKD in puberty for these kids. So all of them should be monitored for hypertension and proteinuria. And so I think those are probably the biggest things. And congenital anomalies, the reason that they're important for adults is a lot of times we screen kids regularly in childhood and they tend to do well. But the lifetime risk, for example, for things like posterior urethral valves, which we often think of as a pediatric problem, we don't think about it much in adults. Almost 30% will develop stage 5 CKD, but about a third of those cases don't progress to that until adulthood. So these things are still important, even if they do well throughout childhood, to continue to monitor and screen for in adulthood. And there may also be other things that are associated with some of these congenital issues that you need to think about screening for. So for example, with posterior urethral valves, there's increased risk of undescended testes, testicular cancers, bladder dysfunction that can lead to progressive CKD in adulthood, and then complications of the urologic repairs, so reflux, UTIs, stone formation, vitamin deficiencies. So all of these things are things that are important to think about when these patients transition to the adult world. In terms of kind of difficulties treating pediatric CKD, because again, I think a lot of times we get these patients and say, what are the pediatricians doing? This is kind of crazy. So one thing to know is that there's obviously many fewer medicines for pretty much any complication of CKD that are approved in pediatrics. So for example, hyperkalemia is a big one that I think of. Kayexalate is the only medication for hyperkalemia, unfortunately, that is approved in pediatrics, whereas in adult care, you have many more options like Lokelma, better options, frankly, fewer antihypertensive agents. And there's also issues with formulations in pediatrics. So for some of these young patients, some of these medicines just may not come as liquids or formulations that they can take or in doses that they can take. In addition to fewer approved therapies, many patients, again, experience a more rapid progression of CKD in adolescence. So in addition to the typical issues with compliance in adolescence, there is actually just a natural, rapid progression of CKD. And so I think that's important to think about as these patients are transitioned. So in terms of transitions of care, which is my absolute passion in life, so a little bit about the difference between transfer of care and transition of care. So transfer of care is what most of us do. Unfortunately, it's a discrete event. It's when a patient moves from an adult, from the pediatric world to an adult or adult clinic or care team. And that typically happens because of things like age, just policies, we won't see you after you're 22, 23, et cetera. Geography, going to college, things like that, or clinical status, like the need to start dialysis. And a transfer of care can happen and often does happen without an appropriate transition of care. Whereas a transition of care is a planned structural process based on transitions developmental milestones. So similar to pediatric developmental milestones like walking, crawling, babbling, talking. There are actual transitions, developmental milestones of when pediatric patients should be able to do certain things. So when they should be responsible for a certain percentage of their medications, their refills, know their medications, know what they do, know the side effects, how much they should be speaking during each visit. There's all actual milestones for those things. And it's about slowly building autonomy, knowledge, and self-management skills over time. It also includes the changing role of the family and an increasing need for autonomy and confidentiality, and kind of a step back from and of the family members who have been managing this disease for a very long time. And it requires a handoff between teams and then follow up after that handoff and after that transfer of care to ensure a successful transition. So why do transitions matter for adult providers other than not wanting a 30-year-old to have a mother who's still speaking for them in the office, which can be a very frustrating experience. So there's limited data on the progression of CKD at the time of transition, a lot of data on the progression during adolescence, but those may be different time points. But from transplant data, we know that compared with individuals with the same time since transplant, so individuals who are 25 to 29 years compared to those that are 17 to 24, the death-censored graft failure rates are the highest in those age 17 to 24, and a third of those graft failures in the adolescent age group at the time of transition specifically are unexpected. 30% failure rate of transplant within the first 36 months of transfer to adult care. And there have been transplant transition clinic models, for example, in Canada, that have demonstrated both a decreased incidence of death or graft loss with transition clinic, as well as significant cost reduction. So partnering with your pediatric nephrologists and your pediatric institutions where you're receiving these patients from is really important. It will help your patients to do better. It will make your life much easier as an adult nephrologist, and it will also help you understand how to better manage these patients. So in terms of the pediatric team tasks and what you all should be asking of them, they should be providing a verbal and written summary of the demographics, the relevant clinical information, notes and labs, med list, problem list, all the typical kind of things that you'd expect in an anticipated date of transfer. I realize this often doesn't happen, but it should. And other things that you want to know from the pediatric care team, in addition to just things like the medication list. I feel like a lot of times we kind of get these patients and we say, like, what were they doing? What were they thinking and why? And what we oftentimes need to think about is either they may not have had the same options because they're just not available in pediatric formulations, liquid formulations not approved in pediatrics, or they may have failed it, or the data may actually be different when there's a pediatric onset of disease. So those are all things that you will want to know. And then in terms of the adult team tasks, so the orientation to adult care, review of medical records, and again, those distinctions between pediatric and adult care. So just like anything in medicine, if you ever think that something that someone else does is crazy, talk to the person and figure out why. Because very often there's a reason that we're just not understanding. Helping to continue to strengthen those self-care skills, which should have started on the pediatric side but may not have. Discussing confidentiality and access to information. Discussing best methods of communication with the adolescent and young adult, and then ongoing communication with the pediatric provider during the time of transition. And I think also really kind of helping orient them to adult care and understanding how it's different is going to be something that's very important. In terms of post-transition monitoring, the pediatric team should stay available for support, but the adult team is established as the primary team. There should be ongoing assessments of competencies in adult care. So if you notice that when they're transitioned that they have deficiencies in certain areas, then that is something that is important to think about and talk to them about, or how we're going to get them to increase their competencies in those self-care skills. Assessments of adherence and documentation of the reasons for non-adherence and addressing those issues. So is it willful non-adherence? And if so, why, right? So adolescents don't have the same reasons as adults do for wanting to take their medicine. So for a 50-year-old, you may be able to say you need to do this, it's important for your heart, or it's important for your bones. You can't say that to adolescent patients. It's not what's important to them, and it's not what matters. And keeping themselves healthy is what what matters, but it's for a different reason and for different goals, right? So it's for things like going to college, having independence from their parents, not being embarrassed by their parents, going on dates and doing all the normal things that we did as adolescents. So it's just a different framing to help get them to understand. Socioeconomic factors, forgetfulness, and again, a good understanding of their neurocognitive status and if they're masking. So we tend to make a lot of assumptions about what our patients can do. But one important distinction to remember is a lot of adults that did not have pediatric onset CKD are very often neurocognitively I don't want to say normal, but if you will, versus some of our patients have significant neurocognitive difficulties that they mask really well. So for example, I have patients that you ask them to set an alarm on their phone to remember their medicines, but they don't know how to set an alarm. But they don't want to admit that to their provider until you actually ask them to do it in front of you. And again, they're very good at masking these things in front of their peers because it's embarrassing for them. And then monitoring of long-term outcomes. So in terms of take-home messages, so for nephrotic syndrome, most children can be empirically treated with glucocorticoids without a kidney biopsy. I think that's very important, both to know, if that's ever on the boards, and then also just when you get these kids in terms of why they haven't had a kidney biopsy. Response to steroids is typically rapid, but frequent relapses and steroid dependency are common. MMF, rituximab, and CNI are all appropriate second-line agents, and it should just be discussed with the patient, kind of the pros and cons of each and which they prefer. Many children do enter long periods of remission post-puberty, but relapses as an adult can also be expected, so it's important to discuss that with them. And then steroid resistance should prompt a kidney biopsy. So not necessarily steroid dependence and not necessarily frequent relapses. The data show that those kids also typically have minimal change disease, but steroid resistance is really a different thing in and of itself. And those kids should have, or adults should have kidney biopsy, a genetic evaluation for consideration of FSGS. In terms of hypertension, so in the pre-adolescent stage, the definitions are based on age, sex, and height. You can always look those up. The first step is always a manual blood pressure with an appropriately sized cuff. Just to know that obesity is unfortunately a rising cause of hypertension in children, but underlying parenchymal disease should be considered. It represents a bigger piece of the pie, if you will, of hypertension in pediatrics when compared to adults. And treatment should be based on the underlying etiology. And then transitions, just to know it's a structured process with ongoing communication between the pediatric and adult provider. So it's not kind of this like hot potato of like tag, you're in and I'm done. But there should be an ongoing communication and ongoing feedback of how the process is going for both sides and what needs to be improved. It can improve outcomes for adolescents with CKD and transplant. And that's really, really, really important for these kids and adults. And there's important considerations, including masking of baseline cognitive dysfunction and a normal prolonged adolescence in those with chronic kidney disease. We need to set expectations for adult care at the first visit. So who's going to be doing the talking, who's going to be in the visit, who's going to be receiving the communications about results and things like that. They should have more frequent follow-up initially. So if you would say follow-up in a year for your typical adult patient with the same problem, you may want to follow up in 3 to 6 months in that adolescent timeframe, in that transition timeframe, because a lot of these patients are not, they may not be used to making their own follow-ups, doing their own appointments. They may get kind of chased down by the pediatrics team if they miss anything. And they're at a very high risk time for progression of their disease, for hospital admissions, for relapses, and for all of these things. But this is intervenable and modifiable. So it's really important to have more frequent follow-up initially until you establish a good relationship with them and know that they're doing well. And then gain an understanding of the pediatric team's rationale to help guide changes of care in adulthood. So, when you see them not just saying like, this is kind of crazy, let's do this or that, let's change all these things, but try and understand what was going on in the pediatrics team mind. Is it different when there's a pediatric onset of disease versus if it's just kind of like, you guys can get SGLT2 inhibitors approved and we have more trouble over here or things like that. So what is the actual difference and why were things done? I think those are the big things for me. I have some references here if you guys are interested. And then I know we'll do a Q&A session later, so hopefully people get a little bit of time back this way.
Great. Thank you, AC.